Hello and welcome everyone. Today we'll be discussing about a very important equation, that is the equation of motion. This is a stepwise guide to understand the ventilator, to understand how adjusting the ventilator affect each parameter. So the equation of motion is the very foundation for mechanical ventilation. It governs the principle of interaction between the ventilator, the patient's respiratory system, and how the gas is delivered to the patient. This equation serves as a mathematical framework which describes how the pressure, the flow, the volume, they interact with each other. Understanding this is very important to understand the ventilator settings and how your settings are affecting your patient's lungs. So why do we need to know this equation of motion? We need to know this because it provides a quantitative framework for understanding the ventilator patient interaction. It explains how changing one variable affects the others during mechanical breaths, and it forms the basis for interacting ventilator waveforms and graphics and guides the clinical decision making while adjusting the ventilator parameters. It enables the recognition of the patient's effort and the asynchrony. So what are the components of this? This is the equation, which is the complete equation of motion. So the first is the airway pressure. This is the pressure generated by the ventilator and delivered to the patient's airway. This is the amount of pressure the machine is contributing to movement of the gas. Next is patient's muscle efforts. This is the pressure generated by the patient's own respiratory muscles. This is if the patient is in a spontaneous mode. Next is the elastic load. This is the pressure required to overcome the elastic recoil of the lungs and the chest wall. Next is the resistive load. This is the pressure required to overcome the resistance of the lungs. This increases with flow rate and airway narrowing. Next we have the set PEEP. This is the baseline PEEP intentionally set on the ventilator to maintain the alveolar patency. Finally, you have the auto PEEP, which is the unintentional positive pressure at the end expiration due to incomplete exhalation, which is the part of the air trapped. So there is a simplified formula for the bedside, which is apart from the PEEP. So when to use this is when you know that the auto PEEP is negligible. Clinicians often use this, and here the PEEP vent represents the ventilator pressure above the set PEEP. This form makes it easier to conceptualize exactly what we are doing during a single breath without the complexity of the baseline pressures, because it answers most of your questions. So knowing the PEEP and the auto PEEP is not really relevant unless there is a significant auto PEEP present. So the clinical interpretation is the total pressure, whether that from the ventilator, patient or both, must overcome two distinct forces, that is the elastic force, the E, and the resistive force, the R. So these are the two main things the ventilator is trying to overcome before it is able to deliver the breath. Understanding this balance is key to optimizing the ventilation, minimizing the patient's work of breathing. So this is a schematic diagram showing the same thing. Here you can see the P vent. This is the pressure generated by the ventilator, and P mus is the pull of the respiratory and the diaphragmatic muscles. So it is both of them combined pushes the air into the lungs. So you have two loads. The load that is overcoming the airway resistance, which is based on the flow, and then you have the compliance of the lung, the elastance of the lung, the elastic load to get the lung expanded. That is your volume part. So P mus plus P vent is the E into V plus R into the flow. P vent is PR plus the resistance and the P elastic pressure. So the concept of control in mechanical ventilation, what do we mean exactly when we say pressure control, volume control? This basically means that you're controlling one side. So there are two sides. As you can see here, there are two sides to the ventilator. There is a pressure side, there is a volume side. So you can control any one. So if it is the pressure is controlled, it is the pressure control. If the volume is controlled, it is the volume control. So the mechanical ventilators can only control one side. The clinician chooses which one. Okay. So it can never be done simultaneously. You cannot control both the sides. It's just not possible. This fundamental limitation shapes how we interpret the ventilator's behavior and the patient's response. So what is volume control? What are we controlling here is the flow and the volume, which are preset and held constant on the ventilator. We will show you each graph later on. What varies over here is the airway pressure, because we are keeping the flow and the volume constant. So the airway pressure changes based on the patient's lungs mechanics, which is the resistive and the compliance part, and any spontaneous effort the patient is having. The disadvantage is that it guarantees a tidal volume, regardless of how stiff the lung is or how resistant the lung is. However, it does have the risk of generating very high peak pressures if your elastance or the resistance is affected. Next is pressure control. Here you are controlling the inspiratory pressure while you are allowing the flow and the volume to manage accordingly. The advantage here is you are limiting the pressure, which will reduce the risk of barotrauma. However, your tidal volume can change because my pressure is limited. So you must make sure that what you are monitoring. So when you are monitoring the volume, that is when you have kept the pressure controlled. So in pressure control, I monitor the volume. In volume control, I monitor the pressure. So there is something which I need to monitor. So that must be kept in mind. The one that is not in control has to be monitored always. The clinical pearl here is the variability that is not controlled provides how the patient's lung and respiratory muscles are responding to the ventilator output. The main problem or the confusion that people have is in PRVC mode. They think you're regulating everything. No, actually not. The pressure that needs to be given is determined by the volume controlled breaths which are initially given, but ultimately the breaths that are delivered in the PRVC mode are pressure controlled breaths. So there is a possibility of the tidal volume not being achieved in PRVC, especially if your peak pressures are going high. So that must be kept in mind. Many people think that if I keep in PRVC mode, then I do not need to monitor anything. No, that is a wrong concept. It is a pressure controlled breath. You have to check your tidal volumes that you're achieving, because the ventilator will not go beyond a particular pressure to give the tidal volume. Though it works like that, it doesn't mean that if the lung is becoming more elastic, or that means less compliant, it will keep on increasing the pressure. It will not. It will depend on the alarms that you have given. If the peak pressure alarm is set low, then it will not deliver the tidal volume. This must be kept in mind. So this is a pressure controlled breath. So as you can see here, the pressure is controlled, fixed. So the flow is descending and the volume goes up over time. What is happening over here is that there is an increase in the elastic load. So because of the increase in the elastic load, the volume is getting more slowly into the lungs and the less tidal volume is being generated. And in this, the resistive part is happening, so the flow is more limited. Because the flow is limited, you can see here the flow is unable to reach the baseline. So the flow is getting reduced and the tidal volume generated can also be less. And in this, you can see there is a patient breath, which means that the patient is also breathing, so which is seen here with the negative swing that we are seeing, and the tidal volumes can also be different. So in pressure control, the peak airway pressure is kept constant. As a result, the flow and the volume are changing predictably over time, following an exponential curve determined by the patient's system's the mechanical properties. So here one of the important aspect is the time constant. Time constant is the resistance multiplied by the compliance. It is shown here as tau. The time constant describes how quickly the lung is getting filled or empty. Specifically, it represents the time required for approximately 63% of the change in volume or flow to occur. The clinical significance here is that one time constant means 63% of the flow or the volume is achieved. Three time constants mean 95% of the flow or the volume is achieved, and five time constant is 99%, virtually complete equilibrium. So to allow adequate time for complete exhalation and to prevent autopy, the expiratory time should be at least 3 times the tau. So this is very important concept. You have to understand this. To prevent autopy, you have to keep your expiratory time 3 times the tau, which you can find out by the 63% of the change. So here you can see this is the steady state. Here is the time constant as the seconds are going, and this is any steady state, that it can be the pressures or the flow, like that. So if you are looking at the inspiratory part, that is the volume and the lung pressures and the flow, as the flow increases, the volume increases. So in the first second you achieve 63%, and gradually in the next tau you achieve the further refinement. So by fifth tau you almost achieve 99% full inhalation or exhalation. So this is the pink dotted line which is showing the decrease, and this is the increase, to give you a concept of the things that are going up and going down. So the flow will go down like this as the volume goes up like this. So how do we interpret this? A short tau, that is less than 1.6 second, means that there is fast filling and emptying. This is in case of low compliance, which means it's a very small lung, which means that it's most likely ARDS, or there is pulmonary fibrosis or some restrictive lung disease. So the clue is that the elastic load dominates the respiratory mechanics. Next is a long tau, which means slow filling. It indicates high airway resistance and high compliance, seen in COPD, bronchospasm. So the clinical clue is resistive load dominates the respiratory mechanics. In bedside assessment, observe the flow time waveform in pressure control mode. Measure or estimate the time to baseline, that is the zero flow. Calculate and estimate the tau by dividing it by 3, or to be more precise, if you want to divide it by 5. Use the tau value to identify whether you are having an elastic or resistive pathology, and adjust your ventilator accordingly. So if you have a short tau, may tolerate shorter inspiratory times. Focus on optimizing the PEEP and the driving pressures. This is more so in ARDS. In COPD, you will have long tau, which requires longer expiratory times. Prevent the air tapping and consider bronchodilators to improve this tau. So if we come now to the volume control, in volume control, the flow is delivered in a constant rate, producing a characteristic square waveform, and the resulting airway pressure curve reveals the distinct contribution of the resistive and the elastic loads. So the early pressure rise on the onset of inspiration when the flow begins is mainly for the resistive load. So the initial pressure spike reflects the force needed for the airway resistance as the gas accelerates through the circuit and the conducting airways. So next pressure rise is because of the elastic load, and finally you reach a plateau when there is constant zero flow. So by comparing peak inspiratory pressure to the plateau pressure, the clinician can distinguish whether I have a resistive problem or an elastic problem. If the gap is too high, it means there is a resistive problem. If the plateau pressure is closer to the peak pressure, it means there is an elastic problem. So this is what you are seeing over here. In this you have an increased elastic load, which means ARDS. So in ARDS, as the pressures are going to be reached very high and very fast, and in this there is a resistive load. So again you will have a higher pressure, but it will be more slow, and it will be from the initial part. Here you can see, because of the initial resistance was not very high, it almost looks like a triangle, while in this case it is immediately higher. And this is when the pressure is taking a breath. So you have a negative swing and the pressure is a scooped up view. So recognizing the patient's effort is important. So why we need to detect this? The patient's respiratory effort adds to or subtracts from the ventilator delivered pressure, altering the predicted flow, and recognizing this is important. It will help us in identifying the patient's and ventilator asynchrony, adjust our trigger sensitivity, our inspiratory time. We need to use this to optimize the sedation and the comfort level of the patient, prevent excessive work of breathing or ventilator fighting. If I am giving the ventilator to reduce the work of breathing and the patient continues to have these breaths, then what is the benefit of it? We have to check this. We have to sedate and give comfort to the patient in initial stages. So inspiratory effort, it is a positive P mass, which means that in volume control, the patient effort lowers the airway pressure below the expected. So the pressure waveform will show a scooping or dipping view. In pressure control, it will show as the passive exponential pressure, showing the flow waveform to appear augmented and more prolonged. You will find augmentation in the flow waveform. And if there is negative P mass, that is active expiration, it rises the peak airway pressure, sometimes creating a pressure spike at end inspiration or during the expiration. In pressure control, the expiratory effort decreases and reverses the inspiratory flow prematurely, distorting the expected exponential decay in the curve. You will find the patient is reaching the inspiration earlier. The key to recognizing the patient effort is to compare observed waveforms to expected passive patterns. By deviation, whether in pressure, flow or volume, this is suggested the patients contributes to or opposing the ventilator's work. So then only you can adjust your ventilator settings. So how do we apply this equation of motion to the bedside? Use the equation of motion to systemically analyze each wave, the pressure, the flow, the volume, identify the components, the resistive component, the elastic component, and the patient's effort. Observe for abnormalities. Distinguish pathologies. Determine whether the patient's respiratory problem is primarily resistive or elastic. Detect asynchrony. See what type of patient is breathing like. Can I see some deviations from the passive patterns? The common things will include trigger delays, flow starvation, premature cycling, double triggering. We will show you details this in later lectures. Now optimize settings. Adjust the ventilator parameters, that is inspiratory time and flow rate and trigger sensitivity and pressure support based on your interpretation. So you have to adjust all these things. The inspiratory time based on the tau, the flow rate, the trigger sensitivity, the pressure support, so that we can optimize the ventilator as best to the patient's effort. So the ultimate goal is to achieve a synchrony where the patient's delivered breath aligns with the patient's pathology, so that the patient is in comfort. So automated application, the modern ventilator increasingly incorporated automated algorithms so that you get the best out of it. So there is something called stress index, which is available in volume control. I'm not going to the details of this. Then you have a flow index, which is available in pressure control. Then you have newer modes like proportional assist ventilation. We'll be dealing in details about each and individual parameters over here. So to summarize, the equation of motion is the foundation for the mechanical ventilation. Control determines interpretation. Knowing which variable we are controlling on the ventilator allows us to interpret the behavior of the other variables and understand how the patient's lungs are responding. So, a deep understanding of the equation of motion equips the clinician to perform more accurate and insightful waveform analysis, detect patient efforts and identify asynchrony earlier, make smarter and more physiologically sound ventilator adjustments, and anticipate complications and to prevent injury. So, mastering the equation of motion transforms the mechanical ventilation from a technical task into a precise patient-centered therapy grounded in physiology and physics. So it has to be grounded in science. Our every decision must be based on science.